Our next speaker is Kristen Bates, Interim Medicaid Director for Healthcare Policy and Financing. Kristen is a longtime leader in this field, having served previously as Director of Strategy, Communications, and Policy at the Community Department of Human Services. She was pivotal in the crafting of legislation for the Opioid and Other Substances Interim Committee. She is currently the Interim Medicaid Director for Healthcare Policy and Financing. No matter how busy she is, she will always work hard to ensure collaboration between state agencies, which is why she's here on the panel with the Behavioral Health Administration and other entities. Thank you so much, Kristen, for all the work you do and for presenting with us today.
Thank you so much, Jamie. Let's see if I can figure this out. All right, so I just want to introduce myself a little bit further. For many of you who know, I come to this work through profession and through personal experience. When I started at the state of Colorado, at the now BHA, then Office of Behavioral Health under Human Services, my first assignment was to write the first application for Colorado's state opioid response. That was back in 2017. That was through the CARES Act. That was President Obama's last act as president, and included the first round of funding for opioid money for the states. At that time, my brother was homeless using heroin on the streets of St. Louis. So I wrote this grant, and I learned from so many of you in this room. I learned from my colleagues. I learned from the people that we worked with. I learned from peers. I learned from community members, and that's how we built this early foundation for money. Now, I'm really excited because now you guys are here and you're going through all of this, and some of you are doing what I learned for the first time, 5 years ago. You're learning some of the language, so I'm going to give you a little bit of an update on the language here. By the way, my brother's doing very well. Colorado Medicaid saved his life, and that's why I'm very proud to work for the Department of Healthcare Policy and Financing. And one of the things I learned was how to use person-first language when I started, which might have seemed like a little bit of like a hassle or a mouthful, and it wasn't what I was used to. Get over it. You guys are going to learn it. It'll be fine. It'll be second nature soon enough, right? So I use person-first language, which means I talk about people with a substance use disorder or people with opioid use disorder, SUD, OUD. I also talk about opioid treatment programs, which is one of the places where we get medication-assisted treatment, MAT, OTP. And I'm going to talk a lot about three terms that are kind of interchangeable. There's the Department of Healthcare Policy and Financing. We are the administrator of the state's Medicaid program, which is branded Health First Colorado. So when I talk about HCPF, Medicaid, and Health First Colorado, those are our state's Medicaid program, right? And then you guys are probably familiar with the Accountable Care Collaborative, which is the way we pay for most behavioral health services here in Colorado, and that's most of the time operated by our health plans, which are called regional accountable entities. Okay, so our mission at HCPF is to improve healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. And really, what I think you all are doing right now, if my thoughts are correct, are trying to build sustainable programs for your communities. So there's kind of three places, and I really want to be here to help you think about from the beginning, from the time you're setting the needs, from the time you're building and expanding and designing these programs and evaluating, sustaining them, why is Medicaid important, and how can you ideally draw down as much federal funding as possible for your programs to be sustained after this money goes away. 18 years sounds like a long time, but the amount of money is coming earlier in the early part, and 5 years in state government, I'll tell you, it feels like yesterday that we started this work. So really, as you're looking at your needs, as you're identifying gaps in the care continuum, don't forget prevention and harm reduction. These aren't the areas of greatest expertise for HCPF, but you've got some other experts over here who are going to help you with that, as well as the Department of Public Health and Environment. The idea is that you've got these grants and flexible funds that really help with the cost of growth. There's growing pains that come with every change that we bring, and we better bring change, right? If we keep doing the same thing, we are not going to get anywhere. So we got to bring change. We've got to be innovative, we've got to be thoughtful, and we've got to build on the things that are working that takes time and money in ways that are really hard to reimburse for. So that's why I think that these grants can be really extraordinary for communities. Building workforce skills, and I'm going to talk a lot more about what we can and cannot pay for with Medicaid funding, but ideally you're creating programs that you can track the utilization and cost of these programs, and then ensure that those programs meet standards for state funds and for federal funds. So what does success look like from a HCPUF perspective? Aligned funding strategies, right? That's what we're here to talk about a little bit. As Dr. Medlock shared, and is a super important value of the state, especially in Colorado, community-based needs are really important. We need to know what the community needs. You guys are here to represent individual, specific, and unique things about your community. But at the same time, we can, at that high level, align those strategies in a way that really makes sure that we're not duplicating funds and that we are being both innovative, but really encouraging evidence-based programs so we know this money is going somewhere where it works. For the providers, we need accessible trainings, we need supports for our workforce, and we need to build our provider network, which I'm going to talk a little bit about, and we need to have reduced administrative burden. So I'm going to ask for your help on that for these providers who are receiving funding from multiple different sources. That's us. And finally, we want to see investments in programs that can be sustained through Medicaid funding. A little bit more about Health First Colorado, Medicaid, HCPUF. We cover 1.65 million Coloradans right now. That's about 1 in 4. Before the pandemic, and in the next year, that number is going to probably start to come down as the public health emergency ends. 1 in 5 is the lowest that it's been, though. So you're going to look at 20-25% of your community that's going to be reimbursed. And I'll tell you guys what, in rural communities, those numbers look different than in some of the suburban Denver communities. What's really important about Medicaid, though, our funding is 50-50 federal dollars. So for every dollar that you get Medicaid to reimburse for your state, we're drawing down $1 of federal funds. This helps our state funds go much further, and this is one of the main reasons why you're going to hear people encouraging you to try to get Medicaid funding as a way to sustain your programs. Health First Colorado covers all services for opiate use disorders. All of the treatment is covered through Medicaid. There is no copay and no deductible for our members. This is huge. This is a really important part about access and something that doesn't happen in a lot of other places, even in Medicare. So let me tell you a little bit about kind of the two ways that our program pays for services. We pay for physical and behavioral health services a little bit differently, and then there's some that fall in between, and some of that's for opioids. So fee for service is how we mostly pay for physical health benefits. That means a provider enrolls with Medicaid, and we're actually the health plan, right? Health First Colorado is a health plan. They bill us, we pay them through our Medicaid information system, and this is a volume-based system that's really limited in our flexibility. Just like any other commercial insurer, we have a list of services that we cover. We say, when are they covered, who is allowed to have them, who is allowed to provide them, and where are they allowed to be provided. Those are the 4 things that we look at every single time a claim comes in. That's pretty limited in its flexibility, right? And it's also a volume-based model. But this is how we've, through our legislature, determined that our medical services are going to be run. This also leads to a single agreed-upon rate for every single one of those services that we provide. Behavioral health care, on the other hand, is paid through the Accountable Care Collaborative through our managed care system. Managed care means that we have a set, you might have heard this as our capitated budget, the state's cap. Like, the capitated budget is a set budget under which we pay for all of our behavioral health services. I'm going to say almost all. These are contracted through the regional accountable entities who themselves are the health plan. So the providers bill the raise, and the raise pay the providers instead of Medicaid billing and then paying the providers, right? So both of these programs have some challenges around really incentivizing volume over value. That means we want to get people into more services. Now, more services generally sounds great, but think about it this way. If you have to go back to a provider or to 4 different providers to get a set of services, that's not ideal. That's not patient-centered care. What we want is more comprehensive services from our providers. What we want to see is more flexibility in funding, and the way we're going to do that is by doing more value-based services in both our fee-for-service and our managed care model. So, what do we cover? Coverage across the continuum. Starting in January 2021, HCPF covers all services for behavioral health, opioid use disorder across the continuum. We cover few prevention and harm reduction services. We've got a little bit there. Screening, brief intervention, referral to treatment, SBIRT, something paid through our primary care providers. We cover overdose reversal in the hospital and in the pharmacy. I'm not going to be able to go through this whole list with the amount of time that I have today, but I would encourage you guys. I see some people taking some pictures. We'll put this up online. Jamie Feld will send it out to you. These are the services that we cover. Now, we do require that providers follow something called ASAM. Who's heard of American Society of Addiction Medicine? Okay, great. American Society of Addiction Medicine is a national organization that sets and determines what is the type, what are the kind of levels of care that a person qualifies for. You guys have heard the term medical necessity. This is something that a lot of people hear about for Medicaid. What we say is when we got approval from the federal government to cover residential care for substance use and inpatient care and detox, what they said is you have to use a national approved, agreed upon set of standards, and they have to apply to everybody. That's the only way we're going to approve this. That is why all of our services have to follow this special criteria. Now, if you don't know about this criteria, ask your local providers. They'll know, they'll tell you all about it. They'll have feelings, they'll have opinions, they'll tell you a different maybe version than I'm going to tell you right now. But what you're going to see is that this American Society for Addiction Management criteria, if you are not following that, we cannot cover the services. If you're like, hey, I want some in-between services that don't exactly match, but they're better for my community, I know it's tough. This is the tough part of getting the sustainable funding. That might be something that you start out funding, but that you help those providers get to a place where they meet the standards of ASAM, because that's what it's going to take for them to bill Medicaid over time. So, this is a fun list. What are the things that we can't pay for? So I thought you guys would be very interested in this. And I have to do a caveat here. Medicaid policy is almost impossibly complex to monitor, and every single one of these things is going to have a nuance. It's going to have an exception. So I'm not here to tell you and walk through the painstaking process of understanding each one of these things, but I'm going to tell you generally, if you're looking to use your dollars to fund things that Medicaid can't, braided funding, this is where you could focus. So, administrative paperwork, right? We know that we take a lot of time, but you guys are going to be giving out grants and community funds. You're going to require your providers to also complete paperwork. And then the shoe is on the other foot. You will see what it is like when you have to track these dollars. You're going to be asking providers to do this, and it's going to be hard. We can't pay them for that time. You could potentially pay them capacity payments. You could potentially pay them if they needed to have an additional staff that all they did was grant reporting and connection between the way that grants are funded and the state funds come through the BHA and through HCPF and through CDPHE. Recovery housing. Medicaid cannot pay for room and board. In fact, the only reason we can pay for residential substance use treatment is because the Behavioral Health Administration pays for the room and board for every single Medicaid member that goes in. We pay for the clinical services that happen in a residence, like a home, so we're kind of like paying for a bunch of outpatient care in an inpatient, in a residential setting, in a home-based setting. We cannot pay for sober living. This is national, this is federal standards, but we know that this keeps people healthy, right? We know that recovery housing, peer services, recovery coaching, sober events, sober spaces in our community where it seems like everybody is drinking and smoking and using drugs on, when you're watching TikTok and things like that. Find sober places for your people in recovery. We can't pay for that, you can. Pilots, testing, innovative programs. We use taxpayer money. We cannot use taxpayer money to test things and try them out and see if they work. We can only use taxpayer money on things that we know work and are allowed by the federal government. This is an area where you can get some expertise. Peer services we can pay for, but only in specific circumstance. This one I did have to put the nuance on there. If you're a licensed provider and you have peers as part of a multidisciplinary care team, so you've got a counselor and a peer, and you've got a couple of other, you've got a caseworker, we can pay for that team. We can't pay for, right now, an individual peer. Recruitment and retention, there's a bunch of workforce things that can be happening. Capital building costs. Some places we're like, I would be able to do that. I would be able to meet these ASAM criteria if I could remodel my building, help them remodel their buildings. Marketing, outreach, engagements. One of the things that we hear from providers is they start providing care and only a few people are showing up. And they've got a full-time staff. And they're like, how am I supposed to cover my full-time staff when only a few people are here? So advertising for services is something we're not allowed to do. You guys are allowed to do that. Help build referral networks to your new providers. You're creating new systems, you're creating new services. Help people know where those services are. Harm reduction, and then again, public prevention programs. So a couple of red flags here for us. This is things that we would really like for you to stay away from, and some of them more than others. The first one is just straight up illegal in Colorado, so pay attention. You cannot charge Medicaid members for services that are covered by Medicaid. Let me give you an example. You've got a new provider. They're providing some kind of counseling. They're like, okay, well, I can't bill anybody yet, so I'm doing a sliding scale and based on income, and so I'm gonna pay people, people will pay $35 to $135 for an hour of counseling. If a Medicaid member goes in there, that provider has broken our laws, and federal laws as well, when it comes to supplementing payments. If you say, for every Medicaid patient that you see, I'm gonna give you an extra $40 because I feel like Medicaid is underpaying you, also illegal. I'm very sorry about that. But that is some of the standards. But what you can do, again, you can pay for paperwork time, you can pay for capacity, you can pay for incentive dollars. These are things that the provider can flexibly use for their own benefit without connecting it to a specific service for a specific member. Again, you get in trouble when you're ignoring ASAM and trying to pay for services that won't be able to be paid for over time. And really, sending Medicaid to unlicensed or unenrolled providers who don't accept Medicaid is another place where you're gonna, what you can do though is, you can pay the provider directly, right? So if a Medicaid member comes in and you're like, I've got a scholarship program, and the provider is not billing the patient, but they're billing you, that is allowable. But again, you're gonna be paying for something that the federal government and state government already pays for. Is that what you wanna use your money for? Not saying you can't do it. I'm not saying maybe you can do it for a little bit of time, but ideally that is not a long-term solution. Some orange flags, again, using grant funds to cover things that Medicaid pays for, duplicating state systems or programs, and then this one is data definitions. This sounds pretty technical, but let me explain what it means. If I ask a provider and they have to give me information about how many people they see and when they see them, and you have them give that information as well, except you measure it slightly differently than I measure it, that's like the worst case scenario for providers, because not only are they having to report, but they have to report differently to different providers, and this really causes a lot of that administrative burden challenge, right? So really encourage you to work with your local partners in public health, encourage you to work with your local data and IT experts who know what data definitions are. I know there are some local folks who are very passionate about this. And I think that you just need to make sure that we're not creating new systems where state systems already exist, where you can pull the data just as easily. I'm gonna try to go through the rest of this fairly quickly. Safety net provider network is really essential here. We talk about change and the cost of change. We're gonna be funding a lot of provider supports to make some changes because the Behavioral Health Administration is updating their rules and regulations for what providers do and what safety net services and providers mean. 100% of the opioid treatment programs are covered by Medicaid, so if you're working with an OTP, you are working with Medicaid clients, congratulations, that's fantastic. But expanding our provider network is something that we work on every day. We need more providers doing, and we need our existing providers to do more services for more people. That's what it looks like. Again, why would you become a Medicaid provider? Spread the word. Continuing care for your patients when they change insurance. That's the right thing to do, right? But also, we have no deductible and no co-insurance and no copay. So where a lot of providers take cash only in the behavioral health world, because they're like, I do all this work and then I have to collect $70 from my patient and $70 from the provider, and it doesn't even start for 6 sessions. You start getting paid the full amount from the insurer the day the person walks in the door. And guess what? We also have retroactive coverage for our members, which means that 90 days before they get their insurance, we cover everything that happened to them then. Think about the people who come into the system through a crisis, come in through an overdose, come in through an arrest and a diversion program, which I hope you guys are also funding. But those diversion programs, and then they get into treatment, everything that happened to them before, you can go ahead and start seeing them right away if they're eligible for Medicaid. Eligibility is based on income, it's based on disability status, and it's based on your family size. High standards for our members. This is just a little bit of a plug that I have to say. Again, I know it's tough. I know that Medicaid can be a hard customer, right? And I know that you guys are gonna hear this from providers. I just wanna serve the patients. I don't wanna have to do all that paperwork. That's not medicine. That's not treatment. That's not why I got into this. I want you to understand that the historical exclusion of poor people from our health system is very real. And the reason that we hold these standards is not because we're bureaucrats and we can't figure out a better way. We're trying every day to reduce that. We're working with the BHA to try to help make things streamlined, help make things better. But we have to hold our providers to a higher standard. We cannot have our clinics that are serving Medicaid clients being old and run down and not providing quality care and not meeting basic standards of care, while our commercial payers go into a nice shiny door with a piano player and a fish tank, right? Like, that is not our goal. Our goal is to make sure that our providers all meet a high standard of care, and that is why we require that they report to us. That is why we require that we know exactly where the funding comes from and where it goes. We also pay for evidence-based care, and then there are some things that maybe we want to change, 42 CFR Part 2, for those of you who are in the know, that we can't because they're federal standards, and I'm sorry. Like, keep lobbying, guys. Here's a list, and we've got a number of resources on our website about what we're investing in with HCPF money. Now, we worked super closely with the BHA, as well as the Department of Public Health and Environment, as well as the Department of Law on some of these interim committees and some of this ARPA money, the rescue plan money that came from the feds. And $450 million came through legislation this year, and then we have another $100 million that came just to Medicaid for home and community-based services. This is what we're investing in. Supportive housing. Now, we're not paying for the room and board. These are people who have vouchers, but they need wraparound supports. That's something we're super excited about. Would love to tell you all about it if you guys are interested. We're expanding high-intensity outpatient services. You've got your outpatient care, counseling, individual group, and then you've got your residential care. What's in the middle? For the people who are coming out of residential care, for the people who are long-time users of drugs and alcohol and polysubstances and are like, hey, I need more than an hour of counseling a week to do this. What are those services? What does wraparound care look like? We are paying our raise to expand services. So if you want to know what's happening in your community with $25 million that we're putting out there, ask your Ray. Also, you should just call your Ray and talk to them. They'll be more than happy to talk to you. And I know they might be a new friend for some of you, but I really, really encourage you to speak at the high level to their CEOs, to their executive teams, because they want to be a part of this and they don't want to be double funding things as well. We've got new crisis response models, which are super exciting and allow for substance use sobriety testing and intoxication testing in the field, so we don't have to take someone to the emergency room when they have a mobile crisis and a co-response. We have new technologies for social determinants of health. We've got step up and step down beds coming out for people who have co-occurring disorders, which I didn't even touch on today. There's an impossible, I went backwards. There's like an impossible amount of information again to know about this, and you guys are, some of you just stepping into it, but I got here knowing very little about opioids 5 years ago, and I relied on many of you. I relied on my partners, I relied on my colleagues, I relied on people with lived experience. The information is there for you to grab it. And the BHA is going to be one of the keys to building this system in an aligned and integrated way. They are focusing and putting together a vision. Follow their policies. because we're all going to have to follow their policies at the state. And when you look at how you want to make change, look at how the BHA is setting that example of change, because those standards that they're setting are going to be essential to following through with sustainable programs that are going to be funded and aligned with the state systems. So I want to thank you guys all. I think we've got like a couple of slides on. There's my personal email address, not my personal email address. That's my email address at work. We've got an SUD page, which also says like, if you're a provider, how do you enroll? There's all kinds of resources for providers to enroll and teach you how to do that. So I really encourage you guys to check out our website, to reach out to me directly, to reach out to your partners here at COAC, who are going to tell you who the individuals are on my team, because I have a team of like 100 people who might be able to answer faster than me. But I just want to commend you all for your hard work, the road you're about to set out on, and for helping so many members of our community who need it so desperately. Thank you.
Wow, thank you so much, Kristen, for making a very difficult issue, Medicaid, more understandable. I am going to take pictures myself of those slides about what Medicaid pays for and what it doesn't. That's extremely valuable. If you remember one thing, remember Ray. I should get someone from my regional area entity on my regional council. So if you haven't done that already, think through, hey, I don't want to be paying for something that Medicaid's paying for. Remember, some of these things are illegal too. So you really want to make sure that you're in touch with your Ray. I also just want to say, I want to find that place that has the fish tank and the piano player. I haven't found that for my own, but that sounds amazing. But not evidence-based. So really just great speakers we have here today. The Behavioral Health Administration, the Medicaid, the office, the HCPOF, these are going to be your primary partners when you think about braiding funding. You don't want to go in this alone. There are funds that are coming from the state. You don't have to spend all your opioid settlement funds on this. There are existing resources. And so that's what our next speaker is going to be speaking about. We are very fortunate to have Amy Cooper, Associate Director of Adult Treatment and Recovery at the Behavioral Health Administration. Amy oversees a team focused on federal grants specific to substance use and mental health at the state. She's going to speak about the complementary state-targeted opioid response grants. You may have heard of SOR 1, 2, and 3. I think Kristen was referring to SOR 1. Is that right? STR. And that has increased in funds from 20 million to now it's up to 40 million. And so 40 million coming from the state on opioid specific funds. You want to know about what they're paying for so that you don't have to pay for the same thing. Amy also has considerable experience as the former state opioid treatment authority, which she can speak briefly about as well. So thank you so much, and we'll bring Amy right up.
All right, good morning, everyone. All right, hang in there just a little bit longer, and then I think there's some questions and a break after this. So I will try to keep it lively while we get through some of the braided funding opportunities with the behavioral health. So just to go over what we'll talk about today, we're going to do a brief overview of the state targeted opioid response grants. Note that I kind of mashed the two grants together in that one title, so bear with me. We're also going to identify some of the gaps in the existing system and then review covered services and areas for expansion, utilizing some of your settlement funds. So despite all of the money that is coming in, we certainly still have gaps in the system, but we've also been fortunate to have the dollar amount for our state-targeted response grant increase significantly year over year as the grants have progressed. So Kristen mentioned that she was there for the beginning in 2017 when we wrote the state-targeted response grant for about $20 million. Again, it's increased since then to the state opioid response grant third iteration, or what we're calling state SOR 3. We're anticipating about $42 million to come from that grant. We just finished the application last month, so we're really excited to see what our federal partners will approve and then what we'll be working on in this next iteration. It is a formula grant from SAMHSA, so every state has an opportunity to apply for these funds, and it's divvied up, determined by the impact of the opioid crisis in your state. So a few things that we've done in the past with these opioid funds are increase access in treatment deserts with 6 mobile health units. You may be familiar with them, but on board we have telehealth to a practitioner who can prescribe buprenorphine products, a nurse or medical assistant, and then a peer or treatment recovery specialist who's able to work with the individual and bring their lived experience to the table. We also worked with Colorado Hospital Association and funded 7 prescription guidelines for alternatives to opioid prescribing. So really working with hospitals and emergency departments to move away from opioid prescribing for pain and looking at different alternatives. We have distributed over 112,000 naloxone kits. That number has increased since the slide was created, which we're really excited about. But we've been able to work with our partners at the Colorado Public Health and Environment to distribute these naloxone kits through the Naloxone Bulk Fund. So that's something I really want to earmark to make sure folks are aware of. If you're planning your settlement funds to fund something like naloxone, we actually already have that as a resource. So making sure you're aware of it, and if you have any questions about it, feel free to reach out to any of us up here, and we'll happily guide you in that direction. We also have our peer manager, who is Victor King. Victor is excellent. He's a peer with lived experience, and he works with training our other peers who are working on their certification to be peer support specialists. So again, peers are folks with lived experience either in behavioral health or mental health, or substance use or mental health. And they can support others in really understanding what it's like to walk through the doors of a treatment center. What is it like to get to an OTP or an opioid treatment program and get your first dose of methadone or buprenorphine? So again, Victor also oversees our peer scholarship program. This is funded through our state opioid response dollars. So we're paying for folks to do their training, get their supplies, pay for their certifications so that they can help others in their community. We also have supported Denver and Jefferson school districts who use the American Indian and Alaska Native culture as a prevention source. So really working within that culture and that community to make sure that individuals know that their culture is also a form of prevention. So despite all that, where are the gaps? So I've listed out a few of them here, and I'm going to go into each area in a little more detail. Treatment, recovery, and harm reduction. So Dr. Medlock mentioned earlier that OwnPath was launched earlier this month. It is our provider directory where you can go and find out where are the services in your community. You can look by zip code, you can also look by treatment type, payer source, etc. So this is going to be a great asset as you go to look what's already available and then what are the existing gaps in your region. We also sponsor Opie Rescue, which is a free downloadable app on your phone. It's also a treatment locator, so it will send you to the nearest opioid treatment program, but it also highlights existing buprenorphine providers in your communities, sometimes called OBOTs, or office-based opioid treatment providers. So one example for where braiding funding could be useful in this area is to look at opioid treatment programs potentially expanding through medication units. I know we're getting into a little bit of terminology here, but a medication unit is really that hub and spoke model idea. Oh, okay. I was like, I see myself. That was a little. But it's the idea of the hub and spoke where you would have a home OTP and then you would have a medication unit or a satellite clinic that primarily does dosing, sometimes UAs and testing, but somewhere where folks wouldn't have to drive so far to reach services. So really bringing it back to the community and saying, we recognize you need this service closer to home. So let's talk a little bit more about opioid treatment programs. As you heard Kristen say, I am the former state opioid treatment authority. This was kind of my jam and has been for a long time in regulating these facilities and bringing awareness to the great work that they do. So OTPs are specialized clinics licensed by the BHA with additional oversight from SAMHSA, the Substance Abuse and Mental Health Administration, our federal partners, and the Drug Enforcement Agency. So again, two layers of federal oversight in addition to state licensing. OTPs provide all 3 FDA-approved treatment models. Primarily methadone is the one that we're really looking at here. This is the only place where someone can get methadone is at an OTP. So, the benefit is that we're looking at methadone and its response to fentanyl. And it is very responsive. It's a very good treatment method. We found more and more people are finding success in using methadone than using some of the other available alternatives, though we want to make sure people have choice. So what we're looking to do with the State Opioid Response Grant in this 3rd iteration is really expanding the reach of our OTPs. So, along with our mobile health units, we are going to have 2 mobile opioid treatment programs on the road next year. We're incredibly excited about this. They're currently being built out now, likely to release January, and then sometime in the late spring or summer of 2023. So again, an opportunity for you to pair up with your community-based OTPs and look at how can you support their expansion. It might be through capital expansion, helping them look at renovating a building or purchasing or leasing space, where we could come in and say we can provide dollars for medication, equipment, training, and then actually paying for the medication itself along with our partners at HICBUF. So harm reduction services. I know we've been challenged on the definition of what is harm reduction. So I chose to include the definition coming from SAMHSA, which is really an approach that emphasizes engaging directly with people who use drugs to prevent overdose and infectious disease transmission. So one of the areas I want to highlight that is a current gap in our system is really syringe access programs. Unfortunately, through state and federal dollars, we are not able to fund syringe access services. The Colorado Department of Public Health and Environment is, but we recognize that they're not in every community. Syringe access programs are one of the primary locations where folks are getting naloxone kits, and also fentanyl test strips, which we're going to talk about in a little bit. But those 2 methodologies are really, really important when we think about the continuum of treatment and recovery. All right, so fentanyl test strips, again, we are sponsoring covership of these through our managed service organizations. So they will be available to peers who have received training and are doing some of this outreach work. They will also be available at syringe access programs and on our mobile units. Opioid overdose reversal medications, which you've heard me call naloxone throughout the presentation, we're working on changing our language a little bit because there are new drugs coming to the market that are not naloxone based, but are equally as effective in reversing opioid overdoses. So the CDPHE, or the Colorado Department of Public Health and Environment, has the bulk purchase fund that was recently expanded. So multiple provider types are able to access this fund. So again, as we kind of talked about, if this is part of your plan, I would ask you to just make sure that all of the providers and community members in your region also are aware of the bulk fund through CDPHE. CDPHE can support individuals with getting standing orders. And so it's really, really the hub for where you can get bulk supplies of naloxone. Naloxone is also going to be supported with SOR funds. We're going to be setting things aside through our managed service organizations. So any of those providers who cannot access CDPHE's bulk fund will be able to come to the state and through our MSOs to access them in that way. So it would be a really narrow population who wouldn't be able to access naloxone anywhere else. Excuse me. You can also purchase naloxone through standing orders or through your insurance. So just keeping in mind, again, we've got yet a 3rd resource for folks to access naloxone. So let's talk about building recovery capital. Recovery capital is a phrase that's gaining in popularity as we broaden our understanding of the recovery process. So I put a few examples up here of what recovery capital looks like and how it shows up in different communities. So really, I'm going to dive into a few things a little bit deeper. We've talked about peer supports. I'm going to talk about recovery community organizations and recovery housing. So really working to support your local communities and standing up recovery community organizations which are organizations that provide opportunities for folks in the recovery community to connect with one another, make sure they have resources to community connection, and social supports and activities to promote long-term recovery. So you heard Kristen talk about this a little bit before, but finding those sober spaces can be really difficult. And so making sure that folks have access to resources, know where to find sober spaces, know how to connect with one another, and are receiving support in that way. Is there a way that I get the slides back up there? Oh, there we go. Okay. In addition, I want to talk about recovery housing. So recovery housing is something that Medicaid is unable to pay for. Our grant actually pays for. So we're able to provide support for the first month's rent through the state opioid response grant, and then we're also able to provide ongoing supports as needed for recovery housing through a different funding source. So again, coming to the BHA and making sure that, if we're looking for payment for recovery housing, we've got quite a bit of that covered, but there is opportunity for expansion on the capital side. So CAR is our Colorado Addiction Recovery Resident Certifying Body. They supervise sober living homes that are based on more of a staff facilitated model. So typically somebody who's got some training, maybe a therapist or someone in lived recovery who might not be a peer but might be interested in promoting the recovery community, is running those types of facilities, making sure that if you're looking at sober living and expanding sober living, that the programs are CAR certified. One of the benefits there is to be able to receive state funding. One of the other benefits is for those who are involved in the criminal justice system, that they will need to be CAR certified in order to get those funds as well. So just make sure as you're looking at that, that's something that's included. The other option is Oxford House, which is more of a peer-governed model. So really it's peers coming together in a diplomatic way to oversee kind of how the house runs and operates. So it's 100% peer-led, peer-run, which is really great. Oftentimes we'll see folks who are a little bit further into their recovery in an Oxford House model, and those who are newer in recovery will be in more of a standard sober living home. So again, our funding is really limited to what we can do around capital expenses, but there's a whole range here from implementing egress windows, maybe just 1 or 2 windows in a home can be renovated to use those as bedroom spaces, or to really saying like, we need support in purchasing a whole property or leasing a property. So tying it all together, there's been recent legislative bills that are going to be talked about during this conference that'll support workforce development and capacity building and can be leveraged with settlement funds for greater impact. We went over some of the gaps in treatment, harm reduction, and recovery, but certainly not all of them. And then regional governance councils really have a unique opportunity right now, again, with this influx of funding to make a difference in your community for lasting change. And please keep in touch. Thank you so much.
Thank you to all 3 of our amazing speakers. We'd like to open it up. Yeah, applause, we like, wonderful. We'd like to open it up now for questions. I see Denise here, she's got her hand raised. And maybe if others do too, we can start to keep our eyes open. Okay, great, we've got a couple.
Can you hear me? Oh, good morning. That was an awesome presentation. Thanks for helping to explain all the different buckets. I have a question about patients staying on their medication, particularly methadone in jail. So patients lose their Medicaid in jail, and then what happens is the JBBS funds has the option to either pay for the methadone or not. In some rural communities specifically, they won't allow patients to stay on their medication despite the fact that OTPs, like our Denver Recovery Group, for example, to deliver the medication. I don't see where there's possible, place for SOR funds or possibly Medicaid. I don't know where that lives, but I just wanted to point that out as a gap.
I think that's a really important question. One of the things that we're actually looking at with SOR now and doing some research with existing OTPs, and you'll probably be reached out to by Ryan, our State Opioid Treatment Authority, is really to get an estimate on what delivery costs would be so that we can reimburse through that model. We're also working with our JBBS team with some recent legislative changes that are going to require providers to come up with a different formula for how they're going to accept and maintain individuals on their existing medication-assisted treatment regimen.
Awesome.
And then
Thank you.
I'll just say one addition to that. We just hired our new division director for statewide programs, who was previously the chief behavioral health office for DOC. And so we're hoping that with her integrated expertise in the BHA, we can begin to resolve some of these concerns.
That's awesome.
How do you envision the placement of those mobile units for the targeted treatment centers next year?
Yeah, so we're still working with our managed service organizations to really determine what population we're trying to serve. We've talked about those who are experiencing houselessness and wanting to make sure that we can support those in the community if transportation is an issue and not wanting to leave their personal belongings behind. And so kind of centering that around the metro area. But then we've also talked about how can we have the greatest reach. There are quite a few limitations with these mobile units. They have to return to their home OTP at the end of every day. So we are limited in how far they can go, knowing that that's the caveat that the Drug Enforcement Administration has put in place. But we are kind of working with existing OTPs to see who's interested and then where is the greatest reach that we can have.
And one comment too about the Mat and jails part, stay tuned for our afternoon session. From JBBS, we'll have Becky Huckabee too, so she can speak more to that as well.
I'm going to stand up because I'm so short. You won't see me back here. Hi, I'm Jude Solano. I'm the founder and CEO of Southern Colorado Harm Reduction in Pueblo. And I don't know if this is the right panel or not, but just food for thought. And when we're looking at all the buckets, the bucket about criminal justice, all we're seeing is criminal justice. And my concern, and because our work overlaps greatly with criminal justice and reform, and so when we're talking about that, is there a definition so it cannot be misinterpreted in rural frontier communities that we're still trying to bring up to the 21st century? Is it going to be defined so we cannot build more jails, more arrests are going to be happening because there's criminal justice money? Does that make sense? And the other thing I wanted to ask about is when you're defining harm reduction services, this is great, but it's a very generalized template. We do so much more. And I'm just wondering where input are you getting with respect to harm reduction agencies? Because we touch every piece of what we're talking about here, from active use through recovery, wellness, and healing, and everything that goes along with that, housing, jobs, all of it. That's what most of us do. We just are running underground. So I just want to put that out there. Thank you.
Are you ready for me then? I just have a couple different statements. The JBBS continue working on education of the sheriffs because I'm in a rural area and we're still getting that substance use is a criminal thing, and I'd love to be able to stop the hamster wheel because they need treatment so that they don't continue to go back. And community corrections is an awesome way that we have found in our community. Second of all, on your the Behavioral Health Advisory Council, I would love to put a bug in your ear because a lot of them that were accepted onto that council have not been from the rural areas, true rural areas, and it's a whole different ballgame when you're looking at 5 to 6 hours to get people to treatment than it is when you're on the I-25 corridor. So we submitted a couple people, didn't get put on there, but we have people that have kids that have needs, and it's different in the rural areas. And when we talk about equitable care, we need equitable representation too. Thanks.
point, and I think we've got two. Oh, great, and I just wanted to say a shout out to all the people that came from rural areas here. Just a round of applause. I know it's a long commute, and it's amazing to have you here today, so thank you.
By what process did your brother get from homelessness and addiction to functioning?
Thanks. I love that question. One thing that happened was that he had a severe hospitalization. He had endocarditis, which is a heart infection that you get from injection drugs. During this time, I have a very long speech, and I will put my personal plug in here. Hospitals have to be part of the solution. We cannot do this without them. Thank you. The stigma that he faced in a teaching hospital, like the premier teaching hospital in Missouri, was extraordinary, and the nurses would wait to give him his methadone because they thought that it was nice to see him feeling bad about what he had done to himself. He almost lost his leg, his eyes, has brain damage, is just going to be on disability now because of the heart damage that he sustained during that time. And when I went in and I asked the social worker to come and meet with him about treatment, they said the social worker had already been, and I went and I found on his bedside table a pamphlet on quitting smoking and a ditto, I don't know if you guys use that term, the fax, like an old, overly copied piece of paper, so badly copied you could barely read it, of shelters. Now, for those of you who are familiar with endocarditis, one, you can't get treatment for it twice, for some reason. And two, you usually will get it again if you use injection drugs again. Discharging him to homeless would have been a death sentence. My family and I, took turns flying in and showing the nurses pictures of my brother as a child, crying and begging them to continue his methadone while he was in hospital for 2 months. And then the day that he flew home, we had somebody escort him to Colorado. The day he arrived in Colorado, we filled out a sheet of paper that said he intended to live here, which he did for a few years. He got on treatment that day. He got on Medicaid. And then we took him to intensive outpatient. He did not do residential because he had a safe place to live. And so he could practice his sobriety at home. He had a safe place to live with people who didn't use drugs. He got a job. He stayed on his Medicaid. He relapsed. He went on MAT. And that's how he sustained his recovery for 5 years.
Hello, my name is Troy Schofield, and I'm a private citizen. I live in El Paso County and am involved with the efforts there. I'm personally impacted. My son passed away from a heroin overdose about 18 months ago. And so when I hear that Medicaid is willing to pay for treatment and substance abuse disorder, opioid abuse disorder, that's great. But I happen to know through personal experience, at least in El Paso County, that if you're looking for a bed or inpatient treatment or even a counselor or any of those services, that the number of providers that are available compared to the demand is very inequitable. And you're talking about weeks, if not months, of waiting to get into a treatment. And through the research, focus group stuff that I've had, had access to, been able to read and peruse, I feel very grateful for that. The number one listed barrier for more treatment beds, more options, was a reimbursement with Medicaid. And I happen to work in the insurance industry, kind of in that, so I know it's a little more nuanced, and I listened to some of the things you said. I deal with the billing and administrative part of healthcare, so I know it's not as simple as reimbursement, but I believe that that's probably a major component of it. How is Colorado looking to address that reimbursement issue to attract more providers?
Yeah, thank you so much, Troy. And actually, there was an article in the Denver Gazette just today, or maybe it came out yesterday, about the wait for inpatient treatment. So one, I want to talk a little bit about demand, which was kind of the first question, and before I can get to reimbursement. So one, the demand is the place where we have very limited opportunity to pay providers to build and expand their services. This is where you all come in. We do have some grants. BHA has grants where they're able to do some of this as well, but this is where I don't think it's duplication for us all to spend some money on this, right? Like we need everybody kind of coming together, and it specifically talked about Colorado Springs and some of the weights there. You know, it's a new benefit, and it takes some time for the, you know, theoretically the market to respond. The article talks a little bit about programs that cost $30,000 for a month. Medicaid's never going to be able to pay that, ever. That standard is not something that we can meet. What we can do is try to pay for people when it's medically necessary to get treatment for as long as they need it there, and sometimes that is just a few weeks, and not a 30-day, a 60-day, a 90-day program. Some of these 90-day programs, there are a few of them where some people qualify: co-occurring disorders, criminal justice, the circle programs, things like that. But a lot of times what we have to do is these are the standards that we had to put on this benefit for it to exist at all. So what we are trying to do is, one, to be aware of, our rates are determined in a couple of different ways, but our budget is determined by the state legislature through the budget process. So that is how part of this funding comes to us, right? If we have the state match, the feds will, it is an entitlement program, so if we have the state funding, that we can draw down the federal dollars. And we are considering, you know, we're looking at, there was a inflation bill that was passed yesterday. I think that there are a couple of different ways that we're going to consider this. We're trying to pay for more services. We're trying to expand what we can pay for: supportive housing, more peer services, pay for and support multidisciplinary teams in which it's less costly because you don't have to have as many clinical providers. But I think the challenge is that there is just going to be some limitations on what we're going to be able to pay for at the end of the day. So having your team provide supports for some of the total ongoing costs for care that aren't, again, related to the specific rates of service, to pay for capacity, to pay for additional supports, to pay for building community partnerships, to pay for, you know, some of the funding that's going to these folks is being used for, you know, social service programs. Partner with your social service programs that have different levels of funding and opportunities to pay for this. Have them come in and build those partnerships. That's what I would encourage. We will do our very best to advocate for provider rates that build strong networks. That is something I can guarantee you can hear from us. But there are going to be challenges, and I don't want to give people false hope that we're going to go out there and pay $30,000 for 30 days of treatment, because we're not going to be able to do it.
And thank you, Troy, for just being here today and sharing your story. It really means a lot to have that personal interaction. So thank you. And to build off that, you know, maybe talk to your state legislator. If this is an issue that's important to you, you know, you can talk to your state legislator and see what can be done at the state for provider rates. We've got one last question here. I've got a question in the chat, and then we'll go to the all too promising coming soon lunch. So
Thank you, Jamie. I'm curious how we at HCPF and the Behavioral Health Administration deal with mental health services, combining those with the substance use disorder services that are covered by Medicaid. So I don't have in-depth knowledge of the ACAM criteria, but my understanding is that that's more specific to substance use. So how do we provide those complementary services, and what does that look like from the mental health services standpoint with Medicaid?
So one is really boring and technical, but one of my favorite things: licensing and regulatory standards. That's how we do it. So right now we've changed it so that you have a single behavioral health entity license that allows you to provide outpatient care for mental health and substance use services. That's going to be moving forward in the next 2 years. So one of them is we make it easier for providers to be licensed to not only provide mental health and substance use services, but also serve individuals who, guess what, have both, right? So that's really important. And then again, we're really trying to build up multidisciplinary teams, team-based models, integrated care models in primary care, where they're providing substance use, mental health, and primary care together. There's additional grants for that. But the multidisciplinary teams, I think, is really important. And then recognizing that social determinants of health is going to be for all of the folks that are needing these services. You're going to have to take a look at transportation, housing, jobs, et cetera. So making sure that those services are available for both.
To that is in the crisis system, actually this legislative session, we were able to close one loophole where individuals in substance use disorder crises were being turned away from crisis care. And so we were able to correct that through the crisis bill. I also, in closing, want to just address the issue raised with the advisory council, and we do regret that there were only 20 spots on our lived experience council, but through our mapping, we did cover every corner of the state with those who were appointed. And we want to assure you that there are still going to be regional subcommittees that report into that advisory council, so please encourage your folks across the state to reapply for the regional committees.
I'm going to go to just one question on chat. If questions are short, maybe we could do a 30-second one. But the one through our Zoom is great presentation and very inspiring. Given the intergenerational trauma and recent data on youth suicide ideation and the gaps in youth treatment facilities, what do you see as the opportunity to use this funding to support youth prevention? Or do you think additional prevention funding for youth substance use will be coming from CDPH or the new MBH group? For tomorrow's session on prevention, be here day 2 in the morning. We're going to have a really exciting prevention panel from some of our CDPHE partners and also CSU. But I'll turn it over to you if you have anything else that you want to bring up.
You know, I think for the youth, ensuring that their voice and needs is elevated, there's a couple approaches that I'm thinking about. We would be really eager to think about how the BHA Lived Experience Council, which will have a youth subgroup, can report in or at least coordinate with these regional councils that are talking about how to use funds. We would love to talk about how to do that, Heidi, and if we can think about that. And then the other piece is the Behavioral Health Administration exists in order to form basically networked government, so that through our partnership and formal agreement with the Department of Education is the main way in which we are intended to work in order to support school-based and youth mental health services. So I think leveraging both our youth advisory board and thinking about our partnership with the Department of Education would be one way to do that.
It looks like we are at time, so save your questions for network.